In dogs, excessive production of cortisol or adrenal sex hormones can be associated with secondary changes to the gallbladder and liver that should increase your suspicion of adrenal disease. In this dog with Cushing's disease and a gallbladder mucocele, gallbladder volume was expected to be 7 cc's, but was measured at 25.5 cc's. This is an early gallbladder mucocele from a dachshund weighing 25 pounds with bilateral adrenal enlargement. The gallbladder contains sludge, inspissation, and mucoid plugs. Cushing's patients often have an overfilled gallbladder containing inspissation and mucoid plugs. Current research suggests that excessive cortisol may affect the gallbladder. However, these lesions can also be seen in patients without adrenal disease. Excessive cortisol and excessive adrenal sex hormones, like progesterone and estrogen, can cause excessive fat to be stored in the liver. With excessive fat storage, the liver becomes enlarged and the parenchyma becomes hyperechoic. Liver biopsy may show vacuolization of liver cells or suggest steroid hepatopathy. These same liver lesions can also be seen in patients without adrenal disease. Gallbladder lesions of inspissation, mucoid plugs, severe enlargement, or mucocele should cause the sonographer to suspect and look for sonographic signs of adrenal dysfunction. An enlarged, hyperechoic liver should also increase suspicion of adrenal dysfunction. Sometimes the discovery of enlarged adrenal glands on an abdominal ultrasound examination is unexpected. Remember that standard measurements should be considered to be guidelines. Increases or decreases in adrenal size are not proof of adrenal disease. First, I would suggest you repeat the measurements by a different method to help rule out operator error. Also, consider other results of your ultrasound examination that would support adrenal disease, such as an enlarged gallbladder containing inspissation and mucoid plugs, or an enlarged hyperechoic liver. Recheck the animal's history for signs of polyuria, polydipsia, polyphagia, or other symptoms to support adrenal disease. With gradual onset of symptoms, many owners accept their pet's current behavior as normal. Perform or recheck the animal's serum chemistries and urinalysis for results that support adrenal disease, such as elevated liver values, elevated blood glucose, a low urine-specific gravity. Consider an adrenocorticotropic hormone stimulation test or low-dose dexamethasone suppression test. There is no need to treat the patient if there are no symptoms or laboratory tests to support adrenal disease. However, you should repeat the ultrasound examination in 3 to 6 months to see if progressive adrenal enlargement is occurring. Also, review expected symptoms of adrenal disease with the owner. Patients with a primary disease process often have bilateral or unilateral adrenal enlargement. This dog has neoplasia of the liver. Patient symptoms and blood results usually make it clear that adrenal disease is not the primary cause of patient symptoms. Chronic stress from the primary problem may be causing increased adrenal function and mild enlargement. An ACTH stimulation test is usually in the high normal range and does not support primary adrenal disease. With unilateral adrenal enlargement, the enlarged adrenal is often near an organ that is inflamed. The right adrenal may be enlarged in patients with inflammation of the right limb of the pancreas. The left adrenal may be enlarged in patients with inflammation or neoplasia of the spleen or stomach. Both adrenals may be mildly enlarged with moderate to severe diffuse inflammatory bowel disease. The presence of hyperechoic fat in the area of an enlarged adrenal could suggest chronic inflammation that may be affecting the adrenal gland. Sonographic lesions of the gallbladder or liver that are commonly associated with adrenal disease may not be present. This cat has diffuse inflammatory bowel disease. When chronic stress is suspected to be the cause of adrenal enlargement, I recommend treating the primary disease process and rechecking the adrenal size 2 to 6 months later. This 70-pound dog had a tumor of the spleen and an enlarged right adrenal gland. This patient is a 2.5-year-old Australian Shepherd weighing 50 pounds. The patient showed exercise intolerance and had a BUN of 38. Expected adrenal width was 6 to 7 millimeters. Both adrenals were difficult to find and smaller than expected at 4.1 millimeters. Addison's disease, or hypoadrenocorticism, is not usually diagnosed by ultrasound. The typical Addisonian patient has an adrenocortical failure that is usually secondary to immune-mediated destruction of the adrenal cortex. Most patients show cortisol and aldosterone deficiency. Diagnosis usually depends on recognition of clinical signs and laboratory results. Patients may have chronic waxing and waning symptoms of lethargy, anorexia, vomiting, diarrhea, muscle wasting, polyuria, polydipsia, regurgitation, or seizures. Adrenal reserve must be depleted by 85 to 90% before clinical signs are observed. These signs can also be acute with collapse due to hypovolemic shock. Lack of aldosterone leads to loss of sodium and causes hypovolemia, low cardiac output, low blood pressure, low renal blood flow, and an elevated BUN and creatinine. Liver enzymes may be elevated due to poor liver perfusion. Albumin may be low due to an increased gastrointestinal loss, which may cause diarrhea. Cholesterol may be low because of reduced gastrointestinal absorption. Atypical hypoadrenocorticism patients will have a deficiency of cortisol but not aldosterone, and may not show elevations of BUN, creatinine, or potassium. And atypical Addisons may not have a low serum sodium. A lack of ultrasound changes to explain patient symptoms and laboratory results may increase suspicion of Addison's disease. With Addison's, the adrenal glands may be normal or sometimes small on ultrasound. Most dogs will have a measurable reduction in size of the adrenal glands, and sometimes the adrenal glands cannot be identified on ultrasound. It may be difficult to prove a reduction in size of the adrenal glands without previous measurements from the same patient for comparison. Conversely, the discovery of small adrenal glands on an ultrasound examination does not confirm the presence of Addison's disease. Blood tests are necessary. Abdominal ultrasound is sometimes performed on patients because of elevated liver or kidney values or nonspecific symptoms. Sometimes the adrenal glands may seem small or difficult to find. The combination of patient symptoms, a lack of sonographic lesions to explain symptoms, and small or hard to find adrenals may help to increase suspicion of Addison's disease.